what we start now is with the Mullerian anomalies. Mullerian anomalies, the name itself tells if there's a problem in the Mullerian duct differentiation, or if it doesn't differentiate. So a very high yield area in the exam questions definitely come from here also. So let's discuss the different class. Over the years, many classification systems have come, but the most recent classification is the ASRM, that is American Society for Reproductive Medicine classification. Now, this is not really a classification, it is basically an app. If you take out your Google Play Store or Apple Store, you'll find, and you just type the Mac Tool 2021, you will get this. Okay, so it is basically more than a classification, it is a sort of just a second, I will just change my. Okay, now there should not be any lag. Okay, so what's happening is that if you look at this new classification, that is the MAC tool of 2021, this is the recent most classification. But like I said, it's not a classification per se, like the earlier ones. It is a tool. It is a complete sort of what do you say, division of different different treatment options, because remember, these Muller anomalies, many of them coexist. There's still a lag. I don't know why there's still a lag. Just give me a minute. I'm unable to figure out because all the it's lagging in every way. Okay, now is it better? Yeah, okay. So the classification is more of a tool which helps you with the clinical features, with the investigations, with the treatments. So if you just search on your phones, you will find this. And if you just go by the basic tool, how this classification gives it, it gives it as Mullerian agenesis, which we have discussed. Okay, this could again be partial agenesis or complete agenesis. Then you have cervical agenesis, which is a separate category all by itself. That means the cervix hasn't formed. Then you have unicornuate, didelphys, bicornuate, septate. These were there in the earlier classifications also. Then you have longitudinal vaginal septum and transverse vaginal septum as separate entities. ये पहले वाले systems में नहीं थे. And then you have complex anomalies where you have different anomalies coexisting together. So this is the new classification. It's not important to remember the classification system. Just you should know that the name of the new classification is the MAC Tool 2021. This is Mullerian Anomaly Classification Tool. Okay. Now let's discuss. Now we've already discussed this one. That is, so when we talk about agenesis, we mean MRKH. But as I said, it could be partial also. So if you have agenesis, it can present as primary amenorrhea. But if you have a complete agenesis, you have MRKH syndrome. Okay, this is what it means. MRKH syndrome we have discussed in detail. But if you have vaginal atresia, cervical atresia, it's going to present as an obstruction. And obstruction is going to present with hematocolpos. That means there's an absent vagina or there's an absent cervix. There's going to be hematocolpos, then hematometra. Okay, then there's going to be hematosalpinx, and finally endometriosis. So it basically depends on the level of the obstruction. If we talk about MRKH syndrome, same thing. I'm going to tell you, just give you a quick description of it. We've already done this. So this is going to present with a girl who's going to present with primary amenorrhea with secondary sexual characters present. Okay, in complete agenesis, the uterus is going to be absent. Okay, also absent are all the Mullerian structures. So absent uterus, cervix, upper vagina, and fallopian tubes. Okay, ovaries are going to be present. So the hormonal profile, FSH, LH, estrogen, all of these are going to be normal. Okay, what else should you know? The karyotype is 46XX. There's a 30% association with renal anomalies, so horseshoe kidney, double duplicate ureters. These are all very common. 15% with skeletal abnormalities. Okay, and importantly, the treatment. Treatment is important. You should know that a vaginoplasty, surgical or non-surgical, may be required. Then for treatment for pregnancy, she requires either surrogacy. This is the common way out. Otherwise, rarely what has now begun to be done is uterine transplant. ठीक है? बच्चे writing इसलिए जल्दी लिख रही हूँ because one, my handwriting is bad. Here it is going to be even worse because we've done this. It's just a repetition of what we have done. Okay. Now coming to the different, as I told you, these are the different dilators which you can use. This is the non-surgical technique, and the vaginoplasty, the most common is Makindo, Vecchetti or Davidoff. Both are the other procedures which we have again already discussed. Okay. This is a picture of how the external genitalia looks like. So you have, you can see a Foley's catheter is put in the urethra, and you have the rectum behind. Okay, and you have this blind ending space here. So through this space we basically dissect and create a functional vagina, and the purpose of this is for penetrative sexual intercourse. Okay, so this is about the um, uh, MRKH syndrome, which we have already discussed. Just a few additional pictures I have shown you. Now we come to unicornuate uterus. So we know there are two Mullerian ducts. Okay, both fuse. Okay, and when they fuse, they come together. Initially, it looks like this, then it looks like this, and then it looks like this. So different anomalies are based on problems in this fusion. Now, what is a unicornuate uterus? This is when only one Mullerian duct develops. Okay, what happens to the other Mullerian duct? It either degenerates, disappears, or in majority of patients, okay, in 1/3 of patients, the other duct disappears. Okay, and in about 2/3, it persists as what? As a rudimentary horn. That means this one duct develops into the uterus and the other duct is like this. Okay. Now, how will this patient present? What are the clinical features? So, starting from before she gets pregnant, she can present with infertility because this is a small uterus with less vascular supply. It may not support a growing fetus. So, implantation is hampered. So, infertility can be there. Then, what else can be there? This patient can present with recurrent pregnancy losses, either in the first or the second trimester. Okay. Then she can present with intrauterine growth restriction. She can present with preterm labor, and she can present with malpresentations. In addition to these, if this rudimentary horn has a functioning endometrial cavity, functional endometrium hai, ठीक है, and depending on whether it is communicating or non-communicating. So like in this, here you have a non-communicating rudimentary horn as against something which is communicating. So here you have a communicating rudimentary horn. Okay. In a non-communicating rudimentary horn, what can happen? This endometrium will bleed every cycle. So this will increase in size and present with features of cyclical abdominal pain or worsening dysmenorrhea. So similar to endometriosis. So if there is a horn, it can present as endometriosis. Basically, it's a hematometra which is increasing in size. Okay, so every cycle she'll have worse and worse pain. Okay, and a communicating horn can present with an ectopic pregnancy in the rudimentary horn. And if you have an ectopic pregnancy here, this pregnancy is going to grow. And unlike tubal ectopic, which ruptures in the first trimester, this ectopic pregnancy is going to rupture when? It's going to typically rupture in the second trimester because it's surrounded by thick myometrium. Not enough myometrium to take it to term, बट ऐसा नहीं है कि वो फर्स्ट ट्राइमेस्टर में ट्यूब के जैसे रप्चर हो जाएगा. इट्स गोइंग टू रप्चर समवेयर अराउंड 18 वीक्स 20 वीक्स दैट टाइम. So whenever you get, if you get a clinical scenario, and I always feel that the examiners will ask this someday, the patient comes with shock in the second trimester, always think of rupture in a rudimentary horn uterus. Okay, so it is a rare scenario, but it's something which can be likely asked in the exam. Shock in the second trimester of pregnancy, always think of a ruptured ectopic in a horn. ठीक है, ये याद रखना. So this is what the unicornuate uterus can present like. Now look at this image. This image is, which investigation is this? So this has come in NEET PG 2022. This picture was given and they asked you what is the investigation. The investigation is a hysterosalpingogram. Okay. So what are you seeing here? You're seeing only like a banana shaped. It's called a banana shaped uterus because only one horn has developed, and you can see the fallopian tube is patent here. Okay. So this is how the HSG looks like. However, HSG is a very poor investigation for Mullerian anomalies. Whenever we talk about Mullerian anomalies and their investigation, remember HSG has very poor sensitivity, but it's usually the first investigation we do as part of infertility. इसलिए images इसके बहुत आते हैं. But the best investigation, which is non-invasive, is there is a controversy here now between MRI and 3D scan. MRI is more expensive. Of course, it takes more time. It is not accessible to all. A 3D scan is a very upcoming investigation. It's now very easily available. A lot of people do it also. But still, the gynae books still say MRI is the better investigation amongst both. But a 3D scan is also a good second option. I don't think they will ever ask you a question जिसमें दोनों में choose करना हो, because both are accepted as good investigations. ठीक है? Yes, this is a 3D ultrasound. The best investigation overall, however, and this includes our invasive investigations, is a diagnostic laparoscopy and hysteroscopy. Why is this the best investigation? Because you're not relying on imaging. You're actually looking inside the uterus using a hysteroscope and outside the uterus using a laparoscope. So actually seeing it is obviously better than any imaging, है ना? But it's invasive. So you're not going to, we usually don't do it as a simply as a diagnostic test unless we have a lot of doubt on the MRI. Then we probably will resort to this. Or if you are correcting the anomaly at the same time, or you're using it as an operative or a corrective surgery also, then we will do a laparohystro. Okay, but simply for diagnosis, it's less commonly used. We obviously want to do a non-invasive investigation. That is obviously better. ठीक है, सो जब भी ऐसा क्वेश्चन आएगा, रिमेंबर दीज थिंग्स. नॉन इन्वेसिव में MRI 3D स्कैन ऑलमोस्ट इक्वल. द गायनोकोलॉजिस्ट फील MRI स्लाइटली बेटर. ठीक है, एंड इन्वेसिव इज डायग्नोस्टिक लैप्रोस्कोपी हिस्ट्रोस्कोपी. ओवरऑल अगर पूछा जाए तो लैप्रोस्कोपी हिस्ट्रोस्कोपी इज बेटर. फर्स्ट इज नॉट ऑलवेज HSG, डॉक्टर मीटियोर. What I meant to say is HSG is usually the first investigation as part of infertility workup. We usually do HSG is the first tubal patency in a patient with infertility. ठीक है, तो many times incidentally we diagnose Mullerian anomalies when we look for tubal patency. Again, it's we rejoin. Is it better? Can you hear me now? I rejoined. आज मजा नहीं आ रहा pediatrician because of the lag. I don't know. I have 4G, 5G. My phone is 5G. Still, it's not. Something is wrong. Still lag. Now okay? Okay. Okay, sorry for this one. I do not know why rupture in second trimester, because bacha there is good amount of myometrium surrounding it. Tube कैसे होता है? Tube बहुत flimsy सा होता है. There is no muscular, hardly any muscular tissue in the tube. So the tube will rupture very early in the first trimester, 6, 7, 8 weeks पे it will rupture. Whereas this will hold the pregnancy till around the second trimester and then rupture. Yes, Airtel है मेरे पास. एयरटेल भी है, जियो भी है, फोन अभी एयरटेल पे, तो एयरटेल पे चल रहा है. ओके, so this is what we should know. Now unicornate uterus में what is the treatment? What can you do? So if you have a rudimentary horn, so these are the types of the uteruses. ठीक है, so when there is no horn, I told you it's seen around 1/3 of patients, there will be no horn. But in majority of patients, there will be a horn present. You don't have to remember कौन सा type है, percentage is not important. Just to show you कि ये कैसे लगता है. So no horn में you won't see rudimentary horn or hematometra. ठीक है, अभी भी lag है, audio में problem है. Just a second. Let me sort this out. Just a second. 1 second. I can't switch off my video. My video has to be on at all times. ठीक है? Okay. Is it better? Okay, continuing. Sorry. So if it's too much of a problem, let me know again. So the horn, so the purpose of showing you this picture is ki in 1/3 of patients, there is no horn. So in this patient, you won't see the ectopic and the hematometra. In this patient, where there is look at the first one, there's communication, यहाँ पे ectopic pregnancy can happen. When there is no communication, what can happen? But it is functional. Here you can have a hematometra or endometriosis kind of picture. एंड ये वाला पिक्चर गलत बना हुआ है. दिस इज बेसिकली नो कम्युनिकेशन एंड नो कैविटी ऑल्सो. इट शुड बी लाइक दिस. ओके, इसमें देर इज नथिंग. इसमें नो, दिस एंड दिस विल प्रेजेंट सिमिलर प्रेजेंटेशन. ठीक है. But if you have either this kind or this kind, what is the treatment you will do? For both of these types, you have to remove the horn, especially if you diagnose this before she has any problems. You have to do excision of the rudimentary horn. But for these two types, there is no surgical treatment. Matlab, if a patient has unicornuate uterus, she has unicornuate uterus. Usko hum, there is no way to increase the space of the cavity. There is no surgical technique which can help her. Okay, so if she has infertility or if she has recurrent losses, the best treatment would be again advise her a gestational surrogate. There is no way you can increase the size of the cavity. So there's no surgical treatment for unicornuate. Only if there is a communicating or a functional horn, it has to be excised. The first is communicating. This is non-communicating, but it has a functional horn. It is functioning. That means there is functional endometrium. If it's non-communicating, no cavity and no endometrium, then nothing to do, nothing to worry about this. Okay. Now coming to the next type. This is a didelphys. Didelphys में क्या है? दोनों Mullerian ducts have developed, but they've developed separately. There is no fusion. They're completely separate endometrial cavities. They're completely separate. ठीक है? So what are the problems you can have in a didelphys? Didelphys usually has a good reproductive outcome. यूजली इसमें प्रॉब्लम नहीं होता है. अगर होता है तो विलियम्स हैज डिस्क्राइब्ड 3 complications. Okay, and we will go by Williams because it's the standard book. There's a higher incidence of abortions, there's a higher incidence of preterm labor, and there's a higher incidence of malpresentations. These are what you see with a uterine didelphys. ठीक है. Now look at this picture here. This is an HSG image. इसमें क्या दिख रहा है आपको? You can see 2 completely separate endometrial cavities with there is no joining, no communication, absolutely. They are completely separate and they even have 2 separate cervixes. They are completely separate, no doubt at all in this HSG picture because they are completely separate. Now with a didelphys, you should also remember is that there is no surgical correction which can correct this. And unlike the unicornuate, isme outcome is good. Why is it good compared to a unicornuate? Because despite them being two separate horns, there is a good vascular anastomosis between both of them. So the vascularity of these horns are good. So you usually don't see complications like fetal growth restriction. Okay, but you may see, ऐसा नहीं कि बिल्कुल भी नहीं दिखता है. But let's stick to what Williams says, and this has come as a question, इसलिए मैं बार बार बोल रही हूँ. Let's stick to what Williams says because the question was from Williams. Abortions, preterm, and malpresentations are more common. Now, the question that came in the NEET PG 2022 was all are seen in didelphys except, and they had given these 3 options, and the 4th option they was given was endometriosis. Now, endometriosis is usually not seen in didelphys unless it is didelphys with what is called as Overa syndrome, which I will explain to you abhi. What is didelphys plus Overa? ठीक है. Vagina can be 1 or 2, Imran. If there is a longitudinal vaginal septum, कभी कभी didelphys के साथ there is a longitudinal vaginal septum. So she will have 2 vaginas. Sometimes the septum is partial, sometimes the septum is complete, sometimes there is no septum. So it depends on whether a septum is there. A longitudinal septum, not a transverse septum. ठीक है. Now, so if the question comes, which is not seen in Didelphys. Then the best option to mark would be endometriosis, because endometriosis is a complication seen when didelphys is seen in the setting of Ovira syndrome. What is Ovira syndrome? Ovira syndrome is OHVIRA. What does this stand for? It stands for obstructed hemivagina plus ipsilateral renal agenesis. What does this mean? So you have didelphys. Okay, so you have a didelphys uterus. Okay, and in this, what you find is that one of the vagina, that means half of the vagina, has a obstruction like this. It's a hemivagina. And on this side of the hemivagina, there is that side the kidney is absent. So renal agenesis on that side. So as a result, क्या होगा? यहाँ पे hematocolpus होगा, hematometra होगा, hematosalpinx होगा और endometriosis होगा. So endometriosis can be seen in didelphys, but only in the setting of an obstruction, which is seen in Ovira syndrome. So the question that came, there was a lot of controversy. Should we mark this? Should we mark one of these? And the other doubt was कि malpresentations भी rare होते. It's not very common, rare होते, but होते हैं. ठीक है? So what should you mark? And the answer would be, because Ovira was not mentioned, it's better to mark the endometriosis as an option, because Williams clearly mentions कि abortions preterm malpresentations होते हैं. ठीक है? Transverse lie is not, so it's not about transverse, it's any malpresentation. And if you see this year's NEET PG, there was a question. Does anybody remember the question? There was a question post cesarean. They had given a picture of two uteruses, and they had mentioned that a cesarean has been done for a malpresentation. I think breech was mentioned. And what is this anomaly that you're seeing? That answer was didelphys, because there were two uteruses. So malpresentations are seen. Okay, and when I say malpresentations, it could mean any malpresentation. Breech bhi ho sakta hai, transverse line bhi ho sakta hai. So Jagdish, just correct that, okay, because this is the new Williams. What I'm telling you, the new Williams clearly mentions that these three. So IUGR and preterm also would be mentioned in the ORR. But give preference to these three: abortions, preterm, malpresentation, because these are the most common that are seen. And the reference for this I'm giving you is Williams. So, जो भी questions बनते हैं, usually the faculty will refer to Williams. Okay. This is the Ovira slide. So you have obstructed hemivagina, which will lead to endometriosis. Okay, that is a chocolate cyst you can see here, because so any obstructive Mullerian anomaly can lead to endometriosis. Okay, so let me just make a separate slide for this. Endometriosis, and we will discuss endometriosis in detail in some time, but endometriosis in Mullerian anomalies, कहाँ देखोगे? Can you help me list it out now? So whenever there's an obstruction, so let's start. We have imperforate hymen. Then we have transverse vaginal septum. Help me. Unicornuate, not plain unicornuate, but unicornuate with a non-communicating functional rudimentary horn. है ना? Then yes, Ovira syndrome, not didelphys. Be very clear. Ovira syndrome with didelphys. Okay. What else? I will add a few more here. One is vaginal agenesis. That means the vagina has not formed. And second, cervical agenesis, where the cervix hasn't formed. So these are anomalies where you will find endometriosis. So the question can come in some form. You should be aware that you can find endometriosis in these. So whenever there's an obstruction to the outflow of menstrual blood. Okay. Now coming to biconvate. Biconvate कैसे दिखेगा? Biconvate, this is again an HSG picture. What is biconvate? You have the two Mullerian ducts which have fused but incompletely. They haven't completely fused. Okay, last slide, yellow. So when they've incompletely fused, you have this picture. Now here again, you see the same set of complications जो मैंने unicorn. What's first written? Imperforate hymen. Imperforate hymen. So if you see the unicorn uterus, the same set of complications. So we start with infertility, then abortions or recurrent pregnancy loss, and in biconjugate, typically we see second trimester losses. That is because biconjugate is very often associated with cervical insufficiency, जो हम पहले पढ़ चुके हैं, ठीक है? Then the same set, preterm labor, IUGR or FGR, and malpresentations. HSG is a good way to diagnose this, but it's not the best way. Remember, actually, it's a poor way to diagnose this, not a good way. And what do you see here? You see a wide intercornual angle. So if the angle is more than 105 degrees, suspect a biconjugate uterus. If the angle is less than 75 degrees, so if this angle was less than 75 degree, that means if it was like this, then suspect a septate uterus on an HSG. So a wide angle is biconjugate, a narrow angle is a septate uterus on HSG. But of course, HSG is not the best way. The best way is again either an MRI or a 3D scan. Okay, would be the better ways to diagnose this. Okay, and what is the treatment? Treatment again, we will resort. So there is a surgical way to join the horns. It's called a metroplasty. So the surgical treatment is Strassman metroplasty. Metro means myometrium, plasty means reconstruction. So you're reconstructing the myometrium. When you reconstruct the myometrium, you get one complete uterus. But remember, this is done very, very rarely. It is done only when a patient comes with RPL with biconjugate recurrent pregnancy loss after ruling out all other options, after ruling out every possibility, every diagnosis, then only will you resort to a Strassman metroplasty, because it's a very complicated surgery. Okay, so surgical treatment, it is not the treatment of choice. Again, it is done only in very, very select patient with RPL. The name of the surgery is Strassman's metroplasty. Metro means myometrium, plasty means reconstruction. I have not done Dhanush, I have not even seen. I had a patient who I had planned, but then I only sent her for a second opinion. Ki should we go ahead or should we not go ahead? She had 4 abortions. Everything else was normal, and still they are still wondering what to do or not. Some people are saying do it, some people are saying not to do it, because once you do a metroplasty, this increases the risk of many complications in pregnancy, including uterine rupture. So it's not something which ki metroplasty kar liya to sab theek ho jayega. There is a huge risk of rupture uterus in pregnancy. Okay. Now coming to septate uterus. Septate uterus kya hai? Septate uterus is when the two Mullerian ducts have fused. When they fuse, there is initially a septum after ruling out other causes of RPL, Sujal. So when there is a fusion, a septum forms. Around 20 weeks of fetal life, this septum dissolves. If this septum fails to dissolve, it results in what is called a septate uterus. And on HSG, it looks like this. The angle is less than 75 degree. Okay. Now, what complications? Same set of complications. Again, infertility is common. Why infertility is common? Because ये जो septum होता है ना, the septum is an avascular structure. तो अगर embryo यहाँ पे implant होगा, it's not going to continue. It's going to be failure of implantation. So infertility, recurrent pregnancy loss, preterm, IUGR, malpresentations, same set of complications you will see in, so you see the same set of complications in uniconjugate, in biconjugate, in septate uterus, and to some extent in didelphys also. Okay, so this is what you will come across. What is the, for septate, what is the investigation of choice? The same way you can treat also is a hysteroscopy. Okay, hysteroscopy, not HSG, remember, is a poor investigation. Hysteroscopy is the best way because you can see and you can treat. How will you treat? You will take a scissors and you will cut the septum. So hysteroscopic septal resection. It's a very easy surgery. Just take a scissors or a resectoscope and just cut the septum. Okay, so this is usually done under laparoscopic guidance because you want to see on top, you don't want to perforate the uterus also. So hysteroscopic septal resection is the treatment of choice for septate uterus. Now this question comes and it gets confusing sometimes. On HSG, although HSG has a poor sensitivity for differentiating these anomalies, still the questions come because it's usually the way anomaly is first diagnosed. Okay, so this is a didelphys, very clear, there is no communication at all. Okay, didelphys में कभी कोई confusion होता नहीं है. Confusion होता है इन दोनों में. क्यों? Because both look like two horns are there. But remember, when the horns are wide apart, it is a bicornuate. And if the corns are nearly, yes, obtuse, acute, you can say. To be very exact, you won't have a compass in the exam, but less than 75 degree acute lag raha hai to septate hai, more than 105 degree lag raha hai to it is bicornuate. Okay, but the best way is either an MRI or 3D scan or a laparoscopy, hysteroscopy. ठीक है. So this is a septate uterus on hysteroscopy. This is how it looks like. Even a bicornuate will look like this. So you always have to have a laparoscopy picture also. On laparoscopy, a bicornuate, you will see two horns. And on laparoscopy, in a septate, you will see a broad fundus. So this is the picture you will see on laparoscopy in a bicornuate uterus. And this is laparoscopy in septate. So you'll see, basically, you'll see a broad fundus. Okay. So this, just if I show you this picture, you can't say this is hysteroscopy. It could be septate. It could be, am I lagging again? Or is it okay? Okay. So just by looking at this, I can't say कि ये septate है या bicornuate. I always should have a laparoscopic picture. That's why the investigation of choice is not only hysteroscopy, it's hystero plus lap. ठीक है. So just write here hystero plus lap. Hysteroscopy, laparoscopy plus hysteroscopy. Okay. And treatment is hysteroscopic septal resection. Okay. So this is a picture showing the septal resection. This instrument is called a resectoscope. You can use a scissors also. This resectoscope basically is electrical energy passes through it. It's a monopolar electrical energy, and you just cut the septum. So it's very easy to treat this. It's an avascular septum. It doesn't bleed, and it's just a 5-minute procedure. Okay. Next is arcuate uterus. Arcuate uterus, remember, has the best reproductive outcome because it has no complications, not associated with any complications. What is an arcuate uterus? It is just a small dimpling at the fundus. Okay, so everything has fused, the septa has dissolved, just fundus पे थोड़ा सा dimpling होता है, ठीक है, which is insignificant, no clinical significance at all. Okay. Previous slide, yellow. Even I can see the video is lagging. I don't know why the video is lagging. My network is showing complete full network. Okay. So arcuate uterus, this has come as a question. The best reproductive outcome is with arcuate uterus. Now, in the older classifications, there was a separate category called DES-induced abnormalities. What is DES? DES is a drug called diethyl stilbestrol. Now, this was a drug used in the 1950s and 60s in pregnant women. Like nowadays, we give progesterone to prevent abortions, to prevent recurrent pregnancy loss. In in that era, what was given in patients with bad obstetric history, with recurrent abortions, recurrent preterm, diethylstilbestrol was given. This was an estrogen analog, a synthetic estrogen. Okay, and it was found, it was given for a lot of women, it was given. But when these women delivered babies, okay, and these babies grew up, so they were called as DES daughters and DES sons. So DES and thalidomide are classical examples of teratogens. Although they have long been banned now, nobody uses them anymore. They are classical examples of teratogens, and a lot of studies have been done. Isliye they like asking this in the exam still, because they're very, very classical examples of how teratogenicity happens. So DES daughters, when they grew up, they would present with infertility. And when HSGs were done, you would find this. What is this? This is a T-shaped uterus, so very fibrosed uterus, okay, which was T-shaped. Okay, the cavity was T-shaped. This was typically found in them. Also, they were found to be at a higher incidence of clear, very rare cancers, which were very commonly found in these girls. Clear cell adenocarcinoma of the cervix and the vagina. Okay. And the DES sons, what were they found to have? These DES sons were found to have hypospadia. So they were born with hypospadias. They were born with micro penis, small penises. So genital and abnormalities, external genital and male abnormalities were found in the DES sons. So this is why it's asked, because of the classical association, teratogenic association, hence they are asked. So although we don't see the DS daughters and DS sons are basically my parents' age now. है ना? So they're in the 70s or 80s. So that era is going out, but it's important. Okay. Now coming to transverse vaginal septum, ये हम discuss कर चुके हैं. So just again, quick, brief explanation. It could be a low TVS, it could be a mid TVS, it could be a high TVS. Also remember, so one classification is the position. Another classification is that it could be a complete TVS, where the patient is going to present with cryptomenorrhea, which we discussed in detail. Okay. Sometimes, however, it is a partial TVS. That means there is a small opening. So the patient will not have um, a primary amenorrhea, but she may come with what? What complaint can a girl who has a partial TVS come with? There is an opening here. She can come with dyspareunia or difficult penetrative intercourse. Okay, so this is one complaint they usually come with, or infertility, because there's an obstruction. The sperm may not find its way upwards. So this is another complaint they come with. So remember, it could be partial also. It may not necessarily be a complete one. If it's complete, we already know the presentation. Okay. And the diagnosis is MRI. The best way to diagnose this is the MRI. Now, longitudinal vaginal septum, this picture is not corresponding to this. This is your O-Vera syndrome. Okay. And longitudinal vaginal septum kya hoga? Longitudinal vaginal septum is going to present like this. So you have the uterus, the cervix, and the vagina, and you have a septum like this. Now, this could be part of a septate uterus, it could be part of a didelphys, okay, or it could be just a longitudinal vaginal septum. How will this patient present with? She's going to present either with difficult penetrations or dyspareunia, okay, or she can present with what? She can present with if it's a partial longitudinal vaginal septum, sometimes they have a septum which is only like this. Okay, these patients, and I have seen patients like this presenting during labor. Okay, and when you do a PV, you find that she is in something like an obstructed labor kind of picture. So what do? It's like a thick band in the vagina. You see the fetal head, above the fetal head, you see this thick band of tissue, which is not letting the baby come down. So sort of an obstructed labor kind of picture, and it's very easy to treat this. At that time, you just take a scissors and snip it off. So just resection of the septum is what needs to be done. I recently had a patient who had come with dyspareunia, and she only said, Ki ma'am, I feel something in my vagina when my husband is trying to have intercourse, तो वो पूरा अंदर नहीं जाता, and I can feel something, and just have a look ki kya hai. So I did a speculum. My speculum wasn't going inside. Then I did a PV and I could feel the septum easily. So what did we do? This case I have posted on Instagram. You can see it. So I actually have put a hysteroscope in the vagina. So I've done a vaginoscopy just to make the video and to show you how it looks like. Okay, and then you just with one snip of the scissors, you can just cut it. So using the hysteroscope, I have entered the vagina and you can nicely visualize it. So go on my Instagram, you will find it maybe about a month back. Okay. Please accept requests. This is not so I have 5 profiles on Instagram. My Instagram profile, which is public, is OBG classes by Dr. Rena. Okay. The one you would have sent a request to would be my personal Instagram. Okay. And then I have a page, a poetry page, which is by the name I Write to Breathe. These are my main public profiles. You can follow my poetry page also. Okay. So OBG classes by Dr. Rena and I Write to Breathe. Okay, you can send me. I'll accept your request also. Those of you who have sent, I usually पता नहीं चलता ना कौन है. अगर कोई student है तो मैं कर देती हूँ usually accept. Okay. Questions, come back questions. So in MR syndrome, all the following will be absent except. Yes, I write poetry. You can follow me on my page. So yes, so ovaries will be present, है ना? बाकी सब and the upper part of vagina will also be absent. ठीक है? Complete failure of the Mullerian duct fusion will result in a didelphys. Okay? Clear? Complete failure. They are completely separate. Anti-Mullerian hormone is secreted by. इसमें 2 options हैं. You messaged me in WhatsApp. I will check. You messaged me today. Today morning, I checked all my messages and I replied to everybody. Maybe I missed. I'll check again. Okay, so this should be better than secreted by the males. Okay, it is by the Sertoli cells in male. Sorry, in the male. Remember, AMH is also secreted by the ovaries. In the ovaries, it is secreted by the follicles. Okay, by the small antral follicles. And we'll be discussing the role of AMH in infertility also. But here the answer is the Sertoli cell. My WhatsApp number, कोई group का link please डाल दो इसमें. I'll put the group link at towards the end. Okay. Identify the Mullerian anomaly on HSG. What is this? This is a bicornuate because the angle is very, very wide apart. Okay. A 34-year-old woman presents with a history of 2 previous first trimester losses. A hysteroscopy, laparoscopy reveals this. So can you see on laparoscopy, what are you seeing? You're seeing a single fundus, but it's very broad. And on hysteroscopy, what are you seeing? You're seeing so is this septate or bicornuate? This is a septate uterus. And the question they've asked is, what will you do? So you'll do a hysteroscopic septal resection. Strassman metroplasty is for bicornuate uterus. Cerclage is for cervical insufficiency. Vaginoplasty we've discussed is to reconstruct or to construct a absent vagina, MRKH, yes. Which of the following Mullerian anomaly is likely to be associated with endometriosis? Again, this has 2 choices. Multiple option correct है. Multiple option correct है. तो C तो है because with rudimentary horn, and also D because didelphys can be seen with the ovira. So if you have a multiple option correct, then both are correct. But if you have to choose one amongst this, then C is a better option, because I told you 60% of unicornuates will have a rudimentary horn, whereas only less than 5% of didelphis will have an ovira. Ovira is a very rare, very, very rare syndrome. You're more likely to encounter a unicornuate uterus than an ovira syndrome. Okay. Regarding MRKH, which is the incorrect statement. Karyotype is 46XX, correct. Uterine transplant is a possible treatment for conception, correct. Secondary amenorrhea is a common presentation, wrong. It's primary amenorrhea. Macindovaginoplasty involves creating a space between the rectum and the bladder. This is correct. Okay. Now coming to infertility, the NEET PG wala question I have put somewhere. I think I've put it after infertility, so you will find it there. I think so. Just let me see. I don't know where I put it, but I put it somewhere. हाँ डाला था मैंने. Anybody can find where I put it? It will come somewhere. It will come because I did put it in the morning only. I put it. Okay. Okay, coming to infertility. Infertility, important points. No break, bacha. We just took a break, है ना? 9 o'clock की तो class start किया. ठीक है, we'll take a break after infertility before benign gynae disorder. So 1 hour ये topic है और 1 hour एक और topic है. 2 घंटे हमें और पढ़ना है. ठीक है, तो this class will go on till 12. Is that okay? We'll take a 5-minute break after infertility and then so 1 hour के 2 topics. ठीक है, so you're all fresh, I think. A nice break we all had for 4 days. I need to take a break because my kids have school tomorrow. I just have to check on them and their bag is packed and all that. So 5 minute ka break लेंगे. Okay. So coming to infertility. Infertility. What is the definition of infertility? It is after 1 year of unprotected coitus, if a couple fails to conceive. Okay, it is, we start evaluation for that couple. So we allow them to try for 1 year. At the end of 1 year, 85% of patients will conceive. That's why we wait. There is no hurry. Okay, zaruri nahi hai ki they will conceive in the first cycle. Questions come on this. So nothing to worry, just reassure. But if the patient is more than 35 years. This is if the woman, not the man. If the woman is more than 35 years, or if she has a menstrual irregularity, then we start evaluation after 6 months of unprotected intercourse. Why is this 35 years important? This is because after the age of 35, the ovarian reserve, there is something called the ovarian reserve. This starts to decline significantly. Okay. And hence the chance of her getting pregnant spontaneously also goes down. And hence we need to start intervening earlier. Hence 35 के ऊपर अगर वो हो गई है या कोई menstrual irregularity है, we won't wait, we will start treatment before. ठीक है. Now coming to the basic problem when you have a patient with infertility or if you have a clinical question on infertility, the problem can be either in the ovaries. Okay, the problem can be in the fallopian tube. The problem could be in the uterus. Okay, there could be problems other places also. There is a cervical factor, infertility and peritoneal causes, rare things. ठीक है, but main हमें evaluation करना है uterus का, ovaries का और tube का. This is your female factor infertility. Okay, which is responsible for up till 40% of patients with infertility. Male factor infertility accounts for 30% of all patients with infertility. both male and female combined infertility accounts for 15%. ठीक है, और कितना बचा? 15% बचा. 15% of infertility is unexplained. That means there is no obvious cause. So female factor infertility accounts for 40%, male factor infertility accounts for 30%, both male and female accounts for 15%, and unexplained accounts for 15%. So अब जो हम discussion करेंगे वो हम करेंगे कि ढूंढना कैसे है, how do we find the cause or evaluation of infertility. So first we will discuss evaluation of female infertility. उसमें we'll be talking about ovarian causes, or how do we evaluate for ovarian infertility, how do we evaluate for uterine factor, how do we evaluate for tubal factor, and then how do we evaluate for male factor infertility. Okay, so when we talk about ovarian factor, we are basically talking about ovulation. Okay, so is this patient ovulating or not? That's the first thing we want to know. Okay, so is the cause of infertility and ovulation? So what are the tests? The first and the most obvious is a basic history. If she is having regular menstrual cycles, okay, then that means she's ovulating. And by the new definition of abnormal uterine bleeding, regular menstrual cycle means what? It means a cycle which is 24 to 38 days duration. Earlier हम इसको कहते थे 21 to 35 days. But अब ये change हो गया, ठीक है? अब a normal menstrual cycle duration is 24 to 38 days. And we will be discussing this in detail when we discuss abnormal uterine bleeding. ठीक है? Second, what are the other tests of ovulation? The other tests could be a basal body temperature test. We will discuss this in infertility, natural causes of contraception, natural family planning methods, basal body temperature. What happens? Ovulation के बाद progesterone rises. Progesterone will increase the temperature of the body by 0.25 to 0.5 degrees Celsius. So a woman who is keeping a track of her basal body temperature, and this is by specialized thermometers, she finds that around ovulation, the progesterone increases. This is a sign that she has ovulated. So retrospectively, we can say that yes, ovulation has happened. Also, progesterone increases the thickening of the cervical mucus. It changes it from thin, okay, to a thick, stretchy mucus like raw egg white. So cervical mucus, if she checks in her fingers at the time of ovulation, it becomes thick and stretchy, which is called a cervical mucus method. What else? So there are something called urinary LH kits. What are these urinary LH kits? So when the LH surge is happening, the serum LH increases. That serum LH will be excreted in the urine. So urinary LH kits are available, which will tell the woman that she is ovulating and when she has ovulated. Okay, what else? If a question comes on the most definitive test, the answer is a day 21 progesterone, or the best test is the day 21 progesterone. It is the best test for confirmation of ovulation. A value of more than 10 nanograms per ml is suggestive of ovulation. Okay. What else? Then also, if you do an ultrasound, and on ultrasound, you can see two things. You can either see the dominant follicle forming, okay, which is commonly done when we do ovulation induction cycles. You can actually see on ultrasound in the ovary the follicle forming. We can also see the endometrium. So the endometrium, which is proliferative, has a different appearance from a secretory endometrium. The ultrasound you can easily make out, and I'll show you some pictures later when we discuss endometrial hyperplasia, whether the endometrium is proliferative or whether the endometrium is secretory. You can easily make out. And then another test which you can do, which is not commonly done because it's invasive, is you can take an endometrial biopsy. And this endometrial biopsy is usually taken in the premenstrual phase. That means suppose a woman comes to you and she says her period was about 25 days back. So you would expect she'll get her period kabhi bhi. So premenstrually, we get an endometrial biopsy, and the biopsy, if she has ovulated, should be what? It should be secretory endometrium. The pathologist will report the type of endometrium. Is it proliferative? Is it secretory? In fact, the pathologist will tell you the day of endometrium also. Is it a day 25 endometrium? Is it a day 20 endometrium? So you can see the day also. So a secretory endometrium will confirm that ovulation has indeed taken place. So these are the tests of ovulation. We usually don't do all these tests if a history is good enough usually to tell you if ovulation has happened. Otherwise, we get a day 21 progesterone test done, because this is one of the best tests to tell us if progesterone, best non-invasive tests to tell us if progesterone has, if ovulation has happened. Okay. Now there is something else. So don't get confused when you see the word tests of ovulation and tests of ovarian reserve. Test for ovarian reserve क्या होता है? Yeah, ultrasound also. Many patients we do ultrasound, we usually do when the patient is, when we have put her on ovulation induction drugs, right? Then we do a ultrasound. Now, test for ovarian reserve. Test for ovarian reserve क्या होता है? Sorry, test for ovarian reserve is basically, so what happens, this is what happens. This is age on the x-axis, and here you have the number of oocytes on the y-axis. As the patient ages, the ovarian reserve is going to come down, right? The maximum ovarian reserve, around 6 million oocytes in the ovaries, is when? Is at 20 weeks of fetal life. So when the baby is an embryo in her mother, this is the time she will have the maximum number of oocytes. When she is born, at birth, she is born with 1 million oocytes. So basically what's happening, these oocytes are continuously undergoing apoptosis. They die off. When she's born, she has 1 million oocytes. At puberty, when she's around 12, 13 years old, she has approximately 400,000. अब lakhs में मुझे नहीं पता कितना होता है. 400,000 is 40 lakhs ना, नहीं कितना, I'm not getting confusing you also. It's 400,000, ठीक है, is the number of oocytes. 4 lakhs, ठीक है. So 4 lakhs or 400,000 oocytes are there at puberty, ठीक है. फिर when she reaches menopause, at menopause she is left with around 400 oocytes. Okay, so this is these have been asked early in earlier exams जब one-liner questions आते थे. अब नहीं पूछते, but you should know the concept that with age the oocytes will keep decreasing, and hence when the woman crosses 35, or if she's had previous multiple failed treatments, especially failed IVF cycles, then it's always a good idea to get the tests for ovarian reserve done so that you can plan her treatment accordingly. Okay, at fetal age, which is 20 weeks of fetal life, पे 6 to 7 million होते हैं. At birth, the girl is born with 1 million oocytes. Okay, so it's best to get an ovarian reserve done if she has crossed 35, or if she has had previous multiple failed treatments for infertility. Then we need to get the ovarian reserve done to know ki what is the value, or what is how is her ovarian reserve, and how to plan her further treatment. So what are the tests of ovarian reserve? The best test ovarian reserve is anti-Mullerian hormone. So anti-Mullerian hormone is secreted by the male embryo. It is also secreted by the female ovary after puberty. Okay, it's secreted by the small pre-antral and antral follicles. छोटे वाले follicles secrete करते हैं. It is a glycoprotein. Okay, and the normal values are between 1 to 6. Anything less than 1 is a sign of poor ovarian reserve, And if it's more than 6, what does this mean? It means good ovarian reserve. Where will you see good ovarian reserve? Which patients will you see a lot of ovarian reserve? In girls or women who have polycystic ovarian syndrome, but it's not used to diagnose PCOS. It is only a marker of poor ovarian reserve, and it also helps determine the treatment response. Okay, so this is what you should know about AMH. Also, you should know it can be done on any day of the cycle. It can be done, but there are some recent studies which are saying it is best done on day 2. But this I am writing as query because ये अभी books में नहीं आया है, guidelines में भी नहीं आया है, but some studies are saying it's best done on day 2. But most other places will say, and this has come as a question, it can be done on any day of the cycle. Okay. Small preantral and antral follicles. Preantral and antral follicles. Now, what are the other tests we can do? Day 2 FSH. What's going to happen to the day 2 FSH? A high day 2 FSH is a sign of poor ovarian reserve. Okay, so a day 2 FSH more than 10 is a sign of poor ovarian reserve. Another test we can do is a day 2 estradiol. So, day 2 estradiol, on day 2, you expect the estrogen levels to be very, very low. Okay, if you go back to our menstrual cycle physiology wala jo tha na graph, the first chapter which we started with today, everything is at a baseline level is low. On day 1 सब कुछ low होता है, FSH, LH, estrogen, progesterone सब कुछ low होता है. But if you find a high day 2 estradiol, you would think कि estradiol high है तो FSH कम होना चाहिए. But no, high day 2 FSH, ठीक है, and high day 2 estradiol both signify poor ovarian reserve. Okay, both are high, signifies poor ovarian reserve. One last slide once, ये लो. So high FSH, high day 2 estradiol levels, and another test is inhibin levels. Inhibin levels, if they are low, low inhibin levels are a sign of poor ovarian reserve. Okay, so what happens is high FSH is going to recruit more follicles. So estradiol levels are going to be high in the beginning of the cycle. Normally you would think menopause के साथ क्या होगा? Estradiol levels कम हो जाएंगे, FSH बढ़ेगा. But remember, this level we are specifically doing on day 2. Day 2 अगर estrogen high है, that means more follicles have been recruited right at the beginning of the cycle because of the high FSH. And hence a high value is an indicator on day 2, remember, not on any other day. On day 2, if the value is high, and on day 2, if the FSH is high, it is an indicator of poor ovarian reserve. Low inhibin values are also an indicator of poor ovarian reserve. Okay. So these, and there is one more test you can just add here. It is no longer done. I'm just adding it here. Number 5 is the, just to complete the list, is the clomiphene citrate challenge test, where what we do is we do FSH levels before and after giving clomiphene. Okay, so it's not done nowadays, but just to complete the list, if it comes as a question, कैसे आता है? All are tests of ovarian reserve except. So these are the tests of ovarian reserve: AMH, day 2 FSH, day 2 estradiol, inhibin, clomiphene citrate challenge test, and one more which I forgot completely, sorry, is the ultrasound test. So all the rest are blood tests. This is an ultrasound test, which is where we check or count the number of antral follicles. So antral follicular count. इसमें क्या करते हैं? इसमें भी again second day of the period पे we do an ultrasound and we count the number of follicles in the ovary. So the ovary will appear on the ultrasound. You will be able to see the follicles in the ovary like this. Okay, they'll be black in color because they contain fluid. So you count the number of follicles in each ovary. If the antral follicle count is more than 10 in both the ovaries, this is combined count, this is normal. Okay, so a count less than 10 is indicative of poor ovarian reserve. Okay, so just to complete, okay, what we just to complete the revise what are the tests of ovarian reserve, starting from backward, because some people are still writing. One is the antral follicle count. This is done on day 2 of the cycle. On the ultrasound, the number of follicles are counted in both the ovaries. If it's less than 10, it's an indicator of poor ovarian reserve. Then we have clomiphene citrate challenge test, which is not important. What you should know, however, is the best test, which is the anti-Mullerian hormone, is the best test. Okay, it can be done on any day of the cycle, but some studies are now saying day 2 is the best time to do it. A normal value is between 1 to 6. Less than 1 is an indicator of poor ovarian reserve. More than 6 is an indicator of PCOS. Day 2 FSH, day 2 estradiol, both high, again indicator of poor ovarian reserve. Inhibin is secreted by the granulosa cells. So a low inhibin, again done any day of the cycle, is an indicator of poor ovarian reserve. Okay? So this is what you should remember. This has come several times in the exam. AMH पे आया है best test. So you should know best test is AMH. बाकी क्वेश्चन कैसे आए हैं? All are tests of ovarian reserve except, or they've given you a list of tests and they've asked you which is the best test. They've given you follicular level FSH, luteal level FSH. So remember, day 2 means follicular phase में आप कर रहे हो. So you're doing a day 2. You're not doing a FSH or estradiol in the luteal phase. You're checking early follicular phase of the cycle. ठीक है? Now coming to tests for tubal patency, this very often comes as a question. It came in this year's NEET PG also. What are the tests for tubal patency? So the initial test, the test which we advise all our patients to undergo when they come for infertility, is a hysterosalpingography. Why AMH is high in PCOS? Because when we discuss PCOS, you'll understand you have more number of follicles. Okay. HSG is the initial test, but it's not the best test. The initial test is HSG. If the HSG shows a problem, if you see a block or a tubal blockage on the HSG, what's the next thing you're going to do? You're going to confirm it. And this came as a question in this year's NEET PG. It's come as a question many times before also. You have to do a laparoscopic chromotubation. Chromotubation to confirm. Okay, so the best test is a laparoscopic chromotubation, but because it's a laparoscopy, it's a surgical intervention, right? You will not do it as the initial choice. The initial choice is always an HSG unless there's a contraindication. If there's a block, the next thing you would do is a laparoscopic chromotubation. Why do we do this? Why don't we directly presume कि इसमें problem है? Why don't we directly presume there's a problem here? Because what happens, HSG is usually done under local anesthesia. ठीक है, तो जब आप HSG में करते क्या हो? HSG is done using this instrument. What is this instrument? In fact, both HSG and laparoscopic chromotubation are done by this instrument. This is an instrument through which we inject the dye into the uterus. So this part is put in the cervix, okay? और यहाँ से हम dye inject करते हैं. This is called a Leach-Wilkinson. Just ignore this. This is called a Leach-Wilkinson cannula. If you don't have a Leach-Wilkinson cannula, you can also, in place of this, use what is called a Rubin cannula. If you don't have either of these, you can use a pediatric Foley's catheter. That is a Foley's catheter number 8. Okay, so pediatric Foley's or a Rubin's cannula. But the most commonly one used and the most commonly asked in the exam is a Leach-Wilkinson cannula. And you should know how this looks like. It's come several times as an image-based question. Now HSG में ऐसे दिखेगा, ठीक है? Foley's number 8, which is pediatric Foley's use करोगे. Pediatric Foley's is number 8. Number 14 is what we usually use in women. In women we use 12, 14 or 16. वो यूरेथ्रा के लिए है. ये हम Foley's कहाँ डाल रहे हैं? हम cervix में डाल रहे हैं. 12, 14, 16 नहीं जाएगा. Only a पतला वाला will go. And if you, those of you who've handled or used pediatric Foley's, it comes with a guide wire. है ना? There's a stillet inside. So it helps guide the Foley's inside the cervix. ठीक है. Now this is the normal HSG. ठीक है. So you can see that not only the tubes you can see, so you can see the nice faint outline of the tube, and then you can see the spill in the peritoneal cavity on both the sides. You see this. So not only does it tell you how the tube, whether the tube is patent or not, it also gives you an idea of the intrauterine cavity. That's why you can diagnose Mullerian anomalies. You can diagnose space occupying lesions, like if there's a polyp or a submucosal fibroid, so you'll see a filling defect like this. You can even diagnose Asherman syndrome. Asherman syndrome, you will find an irregular filling defect in the cavity. So when I said an HSG is the initial test, but you always need to confirm this with a laparoscopic chromotubation, is because this is under local anesthesia. So the tubes sometimes go into spasm because of pain. The tubes have seen to undergo spasm. So it appears like a cornual block. And then you don't know कि ये tubal spasm के वजह से था या actually block है. So it's always better to confirm with a laparoscopic chromotubation. Somebody was asking, ma'am, is it necessary? So we always advise the patient, if there's a tubal factor, that is HSG is not normal, the tubes appear blocked, we always tell the ideal way is to get a laparoscopy done and confirm कि problem है तो correctable है, नहीं है तो then we plan an IVF. Because tubal factor infertility, what is the treatment? The best treatment would be to do an IVF. ठीक है, you're bypassing the tubes completely. So some patients, if the HSG is abnormal, they will say कि directly IVF करा लो, है ना? So they will not be willing for a laparoscopy. They don't want an operative procedure. But the best way, ideally what you should do, if the HSG is abnormal, the ideal way is to first confirm it on a laparoscopic chromotubation. And if indeed there is a block which you can't open, so if there is a block, the next thing we try to recannulate or open up the block. Then we advise an IVF. So this is the order in which we should go, but some patients directly want to go this way. That's a different thing completely. Okay. Now, also, what you should remember, HSG is usually done on day 8 or 9 of the menstrual cycle. The idea is that her bleeding should stop, okay, and it should be before any chance of ovulation has happened. Because if ovulation has happened and you do an HSG, you may disturb a pregnancy which was forming. So day 8 to 9 is the best time to do it. We usually use a radio opaque dye because it has to be visible on the X-ray. This could be oil-based or water-based dye. ठीक है? And the dye is injected through the Leech Wilkinson, and that is done under local anesthesia. Rarely we have to if it's very painful, then we may require general anesthesia, but it's usually done under local anesthesia, or we give a painkiller. Now look at this picture, different HSG images you should be able to interpret. Spasm happens because of pain. If the patient has pain, the tubes go into spasm by themselves. This is a unilateral, correct? This is one-sided cornual block. Usually if tubal spasm is there, you will have a bilateral block. So unilateral block can't be because of spasm. This is one tube is completely open, one tube is a cornual block. But we know at least one tube is patent, right? Look at this one. What do you see here? Here you see a bilateral fimbrial block. And because of the bilateral fimbrial block, the dye has collected inside the tubes and formed a hydrosalpinx. Okay, the initial part of the tube is fine. The latter part dye has collected. So this is a bilateral fimbrial block. with hydrosalpinx. Okay, now on laparoscopic chromotubation, why is it the best investigation? Because you're actually seeing everything. So you're seeing the uterus, you're seeing the fallopian tubes, you're seeing the ovaries, you're seeing the, which dye do we use here? Here we use methylene blue dye because it's very well visualized. The blue color is very well visualized against the pink background. Okay, so this is methylene blue, which is injected inside. Somebody from below will be injecting, and then in real time, you're seeing the spill in the fallopian tube. So the best part of laparoscopy chromotubation is you can see other pathology. So if you're suspecting endometriosis, if there's a fibroid, you can actually visualize everything and maybe correct it at the same sitting. Now questions जो आते हैं, questions आते हैं treatment पे. So I'll cover it here only. Treatment of cornual, of bilateral cornual block. So if the block is at the cornua, what is the best treatment? The best treatment is to try and attempt a hysteroscopic recannulation of the fallopian tube. That means try to open up the tube. How do you open up the tube? We try it hysteroscopically to recannulate the tube. Okay? Or the other option is IVF. Okay? If it is a bilateral fimbrial block, then what do you do? Then again, you try to open up the tube. How do you try to open up the tube? You try to do a fimbrioplasty. Or you try to create a new opening. That means a neosalpingostomy. Or you do an IVF. Okay. So fimbrioplasty or a neosalpingostomy, these are surgical techniques. Or you directly do an IVF. So questions that have come in the past twice, this has been asked. Treatment of choice for bilateral cornal block is a hysteroscopic recannulation. Okay. Now, if there is a hydrosalpinx, if there is bilateral hydrosalpinx, that means the tube is damaged. Okay, the tube is damaged. You can't open up a damaged tube. How do you recanalize the tube? Vinita, good question, but beyond the scope of this lecture, there's a very fine sort of guide wire which is available, and through the hysteroscope, we introduce the guide wire into the ostia. Okay, if I go back and I'll show you one picture. Can you see this picture? This is a septate uterus. Can you see this? What is this? यहाँ पे इस side पे नहीं दिख रहा, but this is the tubal ostia. ठीक है? So through this tubal ostia and under laparoscopic guidance, we try to introduce that guide wire through this. ठीक है? And उससे we try to recannulate the tube. Okay, so just to give you a rough idea how it's done. Now, if there's a hydrosalpinx, ठीक है, the tubes are damaged. You can't open up a tube which is damaged. In fact, a tube which is damaged can be detrimental to a pregnancy. So such a patient, you will advise IVF, right? Because tubes तो damaged है ही, tube को bypass करना है. Tubes को bypass करने का best तरीका है in vitro fertilization. ठीक है, that means embryo बाहर बना के put the embryo in the uterus. But IVF के साथ IVF से पहले it's always a good idea to do bilateral clipping of the tubes or do bilateral salpingectomy, remove the tubes. Why? Because toxic substances from the hydrosalpinx can enter into the endometrial cavity and destroy the growing implanted embryo. So it is harmful. It's been found that IVF in the presence of hydrosalpinx, the success rate is much lower. So clipping means ये uterus है, ये आपके, these are the enlarged, one second, this is the uterus. This is the uterus and you have large hydrosalpinxes. ठीक है? So clipping means just put clips or coagulate, cut off the communication between the tube and the uterus, or just remove these two tubes. Okay, this will improve the success for IVF. Okay, what is neosalpingostomy? अगर फिम्ब्रिया पे ब्लॉक है, ठीक है, या तो उसको ब्लॉक को खोलने की कोशिश करो, दैट्स कॉल्ड फिम्ब्रियोप्लास्टी, या फिर एक नया ओपनिंग बना दो ट्यूब के एंड पे, दैट्स कॉल्ड एज नियोसाल्पिंगोस्टमी. Hydrosalpinx means tubes which have fluid in them. Large collections of fluid have happened in the tube. Okay, and this fluid could contain toxic material which can be detrimental to the embryo. This happens usually because of fimbrial block. If the fimbria is blocked, fluid will collect in the tubes and form hydrosalpinx. Okay, you can put a needle and drain the fluid, Nandini, but it has been found to recur again and again. So once hydrosalpinx is there, the tubes are damaged. You can't correct it. So you have to just remove the tubes or clip the tubes. Okay. The most common cause for tubal factor infertility, good question. The most common cause of tubal factor infertility, anybody? Why does the tube get blocked? The patient तो पूछेगा आपसे ना कि ट्यूब क्यों ब्लॉक हुआ? Is yes, so pelvic inflammatory disease, either because of Neisseria or chlamydia. These are the two most common organisms causing PID, that is salpingitis. Okay, so damage to the tube is most common cause is PID, and in our country, a very important cause is genital tuberculosis. Okay, other causes are endometriosis, because in endometriosis, when we will discuss Abhi, everything gets stuck. Endometriosis is basically endometriotic implants or blood getting collected in the peritoneal cavity. Now, remember, when blood collects in the endometrial cavity, it is like a focus of adhesion. Everything gets stuck to that old blood, and the tubes also get stuck, and that leads to reduced tubal motility, and the tube can't transfer the oocyte into the uterus, or the embryo into the uterus. And previous surgeries leading to adhesions, this will also affect tubal motility and tubal function. Okay, so PID is the most common cause, which could be because of Neisseria, chlamydia, or genital tuberculosis, endometriosis, and previous surgery. CT is chlamydia trachomatis. Okay. Now coming to tests for uterine factor. Here the initial test is usually a transvaginal scan. This is the initial test of choice. You can also do a 3D ultrasound, an HSG, a hysteroscopy, MRI. These are all different tests of uterine factor. Uterine factor ka matlab, it could be anything from an endometrial polyp to a fibroid, and usually fibroids that affect fertility. We'll be discussing this in detail in the chapter on fibroids, but these are usually submucosal fibroids. Okay, that means fibroids that are inside the cavity. These are submucosal fibroids, okay? Or large intramural fibroids. Large intramural fibroids means fibroids in the endometrium. And when I say large, I mean those fibroids that are distorting the cavity. Then there could be Asherman syndrome. It could be a Mullerian anomaly. Okay, these are all causes of uterine factor infertility. Okay, I'll tell you what is SIS. We have a question on that. That time I will tell you. Okay. Next is, so this is female factor. Female factor may mainly, when a patient comes to us, we always look for ovarian factor, okay? And that's usually done by a history. Then ovarian reserve हम करते हैं अगर indicated है, ठीक है? Then we look for tubal factor, that is we usually first get an HSG done, and we usually do an ultrasound, that is a TVS, to look for uterine factor. Basic, this is the basic test. So history, HSG, TVS are our basic tests. Okay, and then for the male partner, we always get a semen analysis. So semen analysis is the basic test, the first tests we do for male factor infertility. Which last slide? Okay, so a semen analysis is the first test we do to evaluate male factor infertility. Of course, we take a history, we look for any sexual problems like premature ejaculation or retrograde ejaculation or any coital difficulty. Apart from that, the next thing we do is a semen analysis. So if the question comes, the test of choice for male factor infertility, the answer is semen analysis. Now, this has slightly changed. The WHO, the one which we were following all along was 2010. In 2000, this is 2021. It has changed. Okay, these changes 2021. Slight change हुआ है, बहुत ज़्यादा change नहीं हुआ, but you should know a few parameters. The ones that you should know are the sperm concentration, the motility, and the morphology. These are your most important three parameters. What is sperm concentration? What is the normal value? It used to be 15 million. Now it is less than 16 million per ml is called as oligospermia. So if the count is less than 16 million, it is called as oligospermia. Okay. Next we look at is the motility. Now in motility, you have different types of motility. So when you have a sperm and you look at it under the microscope, the sperm is moving continuously. Now in so if moving sperm are seen, the cutoff used to be 40%, now it's 42%. More than if the motility is less than 42%, it is called as asthenospermia. Okay, asthenospermia. Now प्रोग्रेसिव मोटिलिटी क्या है? प्रोग्रेसिव मोटिलिटी होता है जो स्पर्म आगे की तरफ जा रहा है, ठीक है? The ones moving which have forward motility. Some sperms you will find are moving, but they'll be moving around in circles. उसका कोई फायदा नहीं है. We want a sperm who is moving in front. That is called as progressive motility. ठीक है? If you want, you can remember this, but एक याद रखो. Total motility is better to remember. ठीक है? And then you have morphology. Morphology, it has not changed. The old and the new is 4%. This has all three have come as questions, but they like asking mostly on morphology. But if you're asked as the best parameter to test the sperm function, the answer is morphology. So morphology ka criteria hai less than 4%. It should be more than 4%. If it's less than 4%, it's called as teratospermia. Terato means shape. So problem in the shape or problem in the morphology is called as teratospermia. And if all three parameters are less, this is a known abbreviation, OATS. OATS क्या है? Oligoasthenoteratozoospermia. मतलब all three parameters are bad. It is called as OATS. So if you get a question saying a patient has OATS, you should know OATS का मतलब क्या है? OATS का मतलब है oligoasthenoteratospermia. ठीक है? Candidiasis cannot cause PID. Akriti, candidiasis causes vaginitis, vaginal infection. It doesn't cause PID. Okay, so most important is morphology. Most important for sperm function is the morphology of the sperm. Okay, so this is one thing, one table that you should know. 16 million, 42%, 4%. 16 million per ml is the concentration, 42% is the motility, and 4% is the morphology. Okay, now coming to the treatment. Treatment of tubal factor we've discussed. Let's start with treatment of anovulation. And the most common cause of anovulation is PCOS. So here I'll be discussing about PCOS also, which is a very, very important topic. Can you just give me 5 minutes? This was not meant to be break, but I just have to see if my kids are sleeping because it is their school tomorrow. So just 5 minutes and then I'll come back. Okay.